Good afternoon, everybody. Good evening, everybody, depending on where you're joining from. My name is Vasu. I'm a professor of internal medicine at The Ohio State University. And I feel very fortunate and privileged to be asked by Dr. Moti to come and present at this forum. The topic that we're going to discuss today is transplant associated thrombotic microangiopathy. We'll discuss a little bit about the diagnosis, prognosis, and more importantly, hopefully, have a very robust discussion about the dilemmas that we face in daily practice. With that, this is my disclosures. I will be presenting data from the MIDAS Consortium, which is a prospective consortium studying TMA. This is fully supported by the National Heart, Lung, and Blood Institute at the National Institutes of Health. I've also received research funding from a couple of companies, but they are not related to the current presentation. And I also serve in the advisory board of Alexia. With that, this audience perhaps does not need a huge background, so we'll make it very brief. As we all know, transplant-associated thrombotic microangiopathy is a systemic endothelial injury syndrome. It affects kidneys, the GI tract, brain, heart, and lungs. Contrary to common knowledge that it affects only kidneys, it actually affects a lot more organs than just the kidneys. And oftentimes, the phenotype manifests itself as transfusion dependent anemia and thrombocytopenia that occurs despite full donor chimerism. Um, Clinically, there may be some overlap with TTP, thrombotic thrombocytopenic purpura, but ADAM TS13 levels in this entity that occurs after transplant are normal, and hence plasma exchange is usually not done because it's ineffective. TATMA has a very high mortality rate and also a high morbidity rate. For those patients who are fortunate enough to survive this complication, they can find themselves either dialysis dependent or have enduring morbidity. So the current therapies involve some oftentimes discontinuation of nephrotoxic agents, supportive care, complement inhibition in areas where complement inhibition isn't available, defibrotide. But we haven't yet had a formal prospective randomized trial yet in TATMA. So I thought that we can start with a clinical vignette, and I welcome the audience to uh, please post your thoughts in the chat so we can see what people are thinking. So, well, this is a real patient. So this is a 25-year-old Caucasian lady who had a severe aplastic anemia that was refractory to horse ATG and cyclosporin. Per guidelines, after failure of ATG, she had a HLA matched unrelated donor bone marrow transplant after receiving reduced intensity conditioning. She engrafted beautifully, and at 30 days, she was 100% donor chimerism. Around day 70, when we, in hindsight, when we uh, uh, show the trajectory of the renal function, you can see that the creatinine slowly increased from 1.2, which is normal in our institution, to 2.3, and the clinical team taking care of her had attributed it to high tacrolimus levels. And at around, but the creatinine continued to persist despite lowering the dose of tacrolimus. Creatinine was now up to 3 milligrams per deciliter, and tacrolimus was discontinued at 8 months post transplant. Shortly thereafter, she shows up very sick to the hospital and had developed dyspnea at rest. She also had profound thrombocytopenia and transfusion dependent anemia. She was found to have an ejection fraction of 20%. She also had edema, and that's what prompted a cardiac workup as well. And a moderate pericardial effusion was noted on a transthoracic echo. At this time, she also had severe hypertension requiring multiple antihypertensive agents along with proteinuria. Her serum creatinine over a period of 4 weeks increased progressively to 7 milligrams per deciliter. So this is where I would like audience participation. What would the differential diagnosis be of a patient who has cytopenias and renal dysfunction occurring 10 months post-transplant? Clearly, everyone saw the title and of the presentation, but I want us to think a little bit about what else would we be thinking. I'll monitor the chat, and oftentimes minimal change disease, which results in a phenotype of nephrotic range proteinuria, can manifest with the elevated creatinine and proteinuria, and that often occurs late after transplant. Medications, some medications we use can be nephrotoxic, and so does infection. Um, whether it's BK virus, hemorrhagic cystitis, or nephropathy, adenovirus nephropathy, or medications that we may use to treat infection can also result in nephrotoxicity. Relapse can cause cytopenias. And of course, the topic that we're about to discuss, which is TATMA. So this is how we also approach this patient. And because the rise in creatinine was so stark over a short period of time, we were hoping to get a tissue biopsy. And then the next question is, what is the best way to diagnose TATMA? And always, if it is feasible, if the platelet count allows, an organ biopsy would be the best option. But there are also clinical diagnostic criteria. There's the BMT-CTN criteria, CHO criteria, um, EBMT criteria. There are a lot of clinical diagnostic criteria as well, along with C5b9. At the time, in our institution, we had an in-house C5b9. We continue to do because of our long-standing institutional interest in atypical hemolytic uremic syndrome. So we were able to send off the test and find that C5b9 was markedly elevated in this patient. So I'm going to show you the renal histology because oftentimes we are shown how it looks like in a patient, but it helps to know how it's supposed to look like normally. So this first picture that you see is a biopsy of a normal kidney, where you see beautiful architecture in the kidney. The nephrons are preserved. The glomerular tubular architecture is intact. And then this is what our patient's kidney look like. You can see complete effacement of the architecture of the glomeruli and tubules. You can also see where I'm pointing, red blood cells. You can see bleeding inside the kidney. That's also fibrin deposits. And then when you look under electron microscopy, and this is something that the nephrologist explained to us, is a significant subendothelial widening, which is often very pathognomonic for TATMA. So since we had the in-house, before I go there, I also want to ask the audience whether they think it can cause irreversible morbidity, or it's something that where the morbidity is reversible. So we have a true or false option. There's no Zoom poll, but if you can post it in the chat, that'd be great. Um, so so then, because we had that in-house test and the C5b9 was quite markedly elevated, we initiated eculizumab. So the y-axis shows the platelet count, the x-axis shows the days post-transplant, and the z-axis shows the creatinine. The solid lines are the platelet count, and the dashed lines are the creatinine. You can see that at the time of eculizumab initiation, the platelet count did go up, but the creatinine lagged behind, and then eventually the creatinine also began to come down, and the platelet count continued to rise to normal levels. So the creatinine decreased to 3.5, so we did not have to dialyze the patient. So we were feeling really good about ourselves, like it's a good save and all that. And then eventually the patient moved from our state to a different state. And I was on a casual phone call. I was calling to check on her. It had been more than a year since she moved. By then, her ejection fraction had also improved. She was able to go on a holiday to Disney World with her family and walk a lot. So we were feeling very good about ourselves that we had somehow prevented this patient from irreversible morbidity. But then on my follow-up call, she told me that after 5 years of starting eculizumab, she was actually on the waiting list for a kidney transplant. So although the kidney function had improved, it never went back to baseline or her normal kidney function. So she was actually on the waiting list for a kidney transplant. This is the reality of severe TATMA. In a young patient, these consequences were quite devastating. So so then we thought about, well, why did this happen? So if you look at the literature, the transplant-associated thrombotic microangiopathy is ultimately a clinical diagnosis. It has diverse diagnostic criteria. Depending on the paper you read, the incidence is either 3% or 73%. It has a wide phenotypic spectrum. It also sometimes can have a subacute presentation as evident in this patient. So it requires dynamic monitoring. If we can't say we look for it 2 months ago and not look for it again. There's definitely an emerging role by multiple groups of complement markers. The only published prospective studies in pediatric and young adolescent patients, and it shows the incidence of TATMA of 21%. This is the table by Dr. Eleni Gavrilaki from Greece. Very nice paper showing how the criteria that we do have don't always agree on each other. The schistocyte nomenclature is not always consistent. For example, in our institution, they don't report as how many per high power field. They don't report as a percentage. It's either absent present. So the standards of how schistocytes are reported have also changed over time. And it's not clear whether in this criteria whether you need all. Sometimes not all patients have all these criteria. So it's been challenging traditionally to make this diagnosis. So all the transplant societies in the world, EBMT, Asia Pacific, ASTCT, along with the Center for International Blood and Marrow Transplant Research, they recognize that this is a problem in that the diagnostic criteria are very varied. It's a nebulous disease to diagnose. And only 8 years ago, TATMA was formally requested as a complication in CIBMTR. So if it's not requested, then nobody's even thinking about reporting it. So you can tell that lack of recognition has been a challenge plaguing this condition. So what this committee did was they nominated representatives from different countries in the world and assembled a task force. So we had Dr. Moise from Russia, Dr. Srivastava and Dr. Cho, the Cho of the famed Cho criteria from South Korea, Dr. Enrique Carrares, a guru in endothelial syndromes from Europe, Dr. Ho, Dr. Dandoy and Jodel, Dr. Shetler Long. And I was privileged to be able to chair this committee to come up with a harmonization of definitions for TATMA. So the charge of this committee was, can this committee define a clinically relevant phenotype of TMA? For that, we had to look at the current diagnostic systems, what were their limitations, what's the level of confidence, and come up with a proposed consensus classification system, along with emphasis on less obvious or less known clinical manifestations. But diagnosis is only half the problem. We need to know, does it really impact non-relapse mortality or survival? So the prognostic criteria also needed to be developed. We need to predict an outcome or a need for an intervention. So we wanted to define a severe TMA phenotype at highest risk of non-relapse mortality. And hopefully that would mean indications for treatment. So by definition, a diagnostic criteria would be considered more sensitive. So you're not missing a diagnosis, but then the prognostic criteria should help refine, actually who needs treatment. And the committee members were by no means representative of all the investigators who are working on TATMA. But that was the committee that the steering committee nominated. And we used the Delphi method, which used a 70% consensus on a Likert scale. So if we put out some statements, do the members say, I strongly disagree, neutral, agree, and strongly agree. So we had to get a score of 4 or 5, which is agree or strongly agree, and 70% of members had to vote in that fashion. And if the votes weren't there, we had to regroup, revise our statements until we achieved consensus. So this was published about last year. So the harmonization definitions for diagnostic criteria and prognostic assessment of TATMA, that's the QR code. It's available public access on PubMed. So just to show the group about what exactly that is, we looked at the only criteria that has been studied prospectively and in more than one center, and that was the Jodel criteria. But we modified the Jodel criteria to have definitions. So, for example, if you can have a biopsy-proven disease in kidney or GI, great. But biopsy-proven TMA in skin wasn't considered because there isn't enough consensus for that. In terms of clinical criteria, you need to meet at least 4 out of the 7 criteria within 2 weeks at 2 consecutive time points. So anemia is defined as, although the patient has clearly engrafted, has had neutrophil engraftment, but they failed to achieve transfusion independence for packed RBCs, You've ruled out other causes, serological causes such as autoimmune hemolytic anemia or major ABO mismatch pure red cell aplasia. The hemoglobin has declined from a patient who's nicely engrafted, but then by a gram, and new onset of transfusion dependence. Similarly, for thrombocytopenia, either primary platelet engraftment failure or higher than expected transfusion needs, or a 50% reduction after full platelet engraftment. LDH, we said elevated LDH above the upper limit, schistocytes present absent, hypertension more than 140 over 90 for adults, C5b9 more than the upper limit of normal, and a urine protein creatinine ratio which is readily available as more than a 1 milligram per milligram. So then in terms of risk stratification, we define both standard risk and high risk. As high risk would be if the peak LDH was more than 2 times upper limit, if a spot random urine protein was more than 1 milligram, and any organ dysfunction, and I'll discuss organ dysfunction in the next slide, elevated soluble C5b9, and if a patient has concomitant high grades of acute GVHD or concomitant infection, they were considered high risk. So, in terms of manifestations, the kidney manifestations could be either a 50% reduction of GFR or a serum creatinine more than 2 times baseline, a patient who requires ventilation and you don't have a clear etiology for why they are vented, pulmonary hypertension using a cardiac cath or a echocardiogram criteria, when a patient has clinically significant serositis and you've ruled out hepatic SOS, and having CNS changes such as confusion, altered mental status, seizures, even if they don't have imaging evidence of PRES, and GI bleeding or intestinal strictures that require medical or surgical interventions. This shows the gamut of organ manifestations that can occur in TATMA. So then we put together a summary that's in the paper. So essentially, we recommend a TATMA screening from day 0 to discharge or day 30. Most times when patients are in the hospital, they get a daily CBC chemistry. We recommend getting twice weekly LDH or at least weekly LDH, weekly schistocytes, and a random spot urine protein creatinine ratio. If there's no concern for TMA, then you screen them weekly from day 30 to day 100. And after day 100, if they have new onset higher grade acute GVHD or chronic GVHD or anything that requires a hospitalization, you can get weekly CBC, LDH, and schistocytes. However, if there is a clinical concern or a positive screen, we recommend additional testing. C5b9, manual review of the peripheral smear, ADAM TS13, a Coombs test, so you rule out serological causes, a DIC panel, so we know that they're not having DIC, and additional organ function as clinically indicated. And the TATMA criteria is shown in the left side of the table. That's exactly what we discussed a few minutes ago. If they do not meet criteria for high-risk TATMA, simply continue weekly testing and monitor their organ function closely. But if they do meet criteria for high-risk TATMA, then consider TATMA targeted therapy and management of concurrent complications. So we hope that these guidelines will be adopted widely, because we really want to know what is the real world relevance or utility of these guidelines. These guidelines were never meant to be a final word, but rather a beginning step, meaning as more and more groups utilize these guidelines, we will know what are the limitations of these guidelines, and we hope this would be an iterative process where we refine, modify the guidelines as and when we have data from groups around the world. So some considerations, limitations of using C5b9, it's essentially a serum biomarker for end organ inflammation. In many centers, it's not readily available. Like even in our center, we have an in-house test, but sometimes it can take up to a week to come back. So it's often not resulted in a time frame that if you have a patient in the ICU with seizures and you want a result quickly, you may not get it in a clinically meaningful time frame. And again, as I mentioned earlier, we sincerely hope that these criteria would be widely adopted and papers come out so we know the limitations of the criteria. And we also think that by defining this criteria, hopefully we've raised the consciousness for people to think about TATMA and will result in an earlier diagnosis of TATMA. So we do have certain dilemmas, and I wanted to list list them, because looking at the dilemmas and then looking at the papers that are there will help us know how much we don't know. So, do we treat TATMA in the setting of concomitant steroid responsive GVHD? Do we treat TATMA when the patient also has concomitant steroid refractory GVHD and it looks increasingly futile and TATMA treatments are not cheap? So, how do we think about it in those settings? When they have concomitant viral and bacterial infections, people are hesitant to use complement blockade. And what do you do when they have another endothelial syndrome, such as hepatic SOS? What can we do about patients who have normalization of hematologic parameters, meaning they achieve transfusion independence for hemoglobin and platelets, but they do have persistent organ dysfunction? Do you continue treating them? Do you switch therapies? And there is also a self remitting mild phenotype that resolves with either the underlying risk factor treatment. Once the GVHD is controlled, they may improve, or you change from tacrolimus to sirolimus and they seem to improve. So there is that phenotype as well. So, which is the phenotype that actually needs an intervention? And also, a word of caution about CNI discontinuation. Oftentimes, I get emails from people saying, hey, I have a patient with TATMA, they also have GVHD, or they had a history of GVHD. Should I just stop the tacro? And I tell them to please be very, very mindful that if you discontinue CNI, thinking that would be beneficial for TATMA, you are very likely to risk a GVHD flare, which will most certainly exacerbate TATMA, which was the problem that you sought out to address in the first place. So you may have one problem in the beginning and end up with two very big problems at the end. So CNI discontinuation should be a very, very nuanced decision in terms of how long has the patient been post transplant. If they are 4.5 months and you're tapering, perhaps you can accelerate the taper. If this is a patient who's never had GVHD and it's beyond 100 days, by all means. So it's not a decision that can be, it's not an intervention that can be routinely recommended. And it is a nuanced decision that takes into account all the other things that are going on with the patient. So let's look at what are the therapeutic approaches, what are the agents available, what is the data that we have. So this is a nice cartoon by animation by Dr. Shetler Long that was published a couple of years ago. So there is damage from conditioning regimen, GVHD prophylaxis or medications, infection, GVHD, or perhaps even patients who come to us, perhaps their endothelium is already damaged. And then the events that happen during transplant in terms of infection, they can result in increased ST2, lower nitric oxide, result in a pathway that results in increased nets, neutrophil extracellular traps, which then activates complement. And even in complement, you know about the classical pathway, alternative pathway, the lectin pathway. Then they recruit more platelets. That results in platelet consumption and microthrombi formation and thrombocytopenia. This cartoon shows about the complement system. So we do have some agents. We have terminal complement inhibition with C5b9. We also have lectin pathway inhibition. We also have C3 inhibition with iptacopan. So there are definitely newer agents that are coming now that act on various even more proximal aspects of the complement system. So let's look at what is available in the literature. So Zhang et al. Did a meta-analysis of 6 studies, 116 patients. They used IWG or CHO criteria. So I made this table that looks at, can you know how many patients actually had GVHD at the time of enrollment, or how many had infection at the time of enrollment? And did the response change based on whether they had an active infection or active GVHD? And oftentimes in studies, it's very hard to even find that information. So the response definition that they used was normalization of LDH, transfusion independence, resolution of organ dysfunction, which all of us would agree is a clinically meaningful response definition. And they showed a response rate of 71%. There was no mention about what was the incidence of non-relapse mortality, and the survival rate was quoted to be as 52%. Then there's a paper from Dr. Sonata Jodel from Cincinnati Children's, who's done a lot of work to shed light on this condition. This was a retrospective single center analysis About 47% of patients had acute GVHD in the entire cohort, and half of them had GVHD at the time of TATMA diagnosis. 84% had multi-organ dysfunction, and there was a 56% CR response noted, and 36% who did not respond at all. And they showed that their rates of higher bacterial infections were not any higher than their baseline rates, meaning patients treated with eculizumab did not have a higher incidence of infection. Couldn't see the NRM, but the 1 year overall survival was 66% in comparison to 17% in a cohort that was not treated with eculizumab. So then let's look at the European data from Dr. Sweck et al. Retrospective 82 patients, 29 center study. 27% did not have GVHD, 26% did not have a viral infection. Their response was much lower than what you just saw in the previous slide. They had a 36.6% rate of complete response, and their overall survival was also lower than what you saw before, which was 47%. Dr. Jodel published last year 21 patients, 3 different centers, a prospective multi-center analysis only for high-risk TATMA. And they defined high risk in 2 ways. One was proteinuria, random urine protein creatinine more than 1 milligram per milligram, and elevated C5b9. And 100% of their patients had multi-organ dysfunction, and 38% of their patients had acute GVHD. And if you see the CR, it was 48%, and 33% did not have any response. 1/3 of their patients had 12 bloodstream infections during the time that they were treated with eculizumab. Their 6-month overall survival was 71%, and you can see it drops to 62% at 1 year. So we still have a lot of room to improve in this condition. Let's look at Dr. Khalid's publication of narsoplimab, published in JCO a couple of years ago. They used the prospective CHO criteria. This is probably one of the few studies that talk about response rates in those with GVHD, which was 63%. Also, identical response rate in those with infections at 63%. And they use both lab markers and resolution of organ dysfunction as the response definition. And they noted that in patients younger than 65, the response rate was 58%. And those older than 65, the response rate was 75%. In those with multi-organ dysfunction, the response rate was 64%. In those with renal dysfunction, 57%, pulmonary 40%, and GI was 100%. That treatment emergent infection rate was 36%. So sizable prevalence of infection. They had about 4 deaths in about 21 patients, and we didn't see the 1 year overall survival reported there. Other centers have also utilized defibrotide. For example, in Asia, complement inhibition is not widely available, and they use defibrotide. Chris Dvorak at Children's Hospital Los Angeles in the US used defibrotide as prophylaxis for high-risk TATMA. So they had 25 patients, 11 were allo, the 14 were auto transplants for neuroblastoma. They showed that when used as prophylaxis, the TMA incidence was 4%. Dr. Martinez Munoz from Spain did a study of 17 patients looking at treatment for adult TMA, and showed that there was a 65% response rate within 14 days of initiating defibrotide. And the NRM was 18% in those who achieved a response versus 85% in those who did not achieve a response. So I'm now going to pivot and share some data. This is not yet published. This is from our MIDAS consortium. So MIDAS stands for microangiopathy, endothelial damage in adults undergoing stem cell transplant. And we adopted the harmonization of definitions criteria in a prospective data set. So we presented this data at Tandem this year in February. So again, just to refresh your memory about Jodel criteria, these are the modified Jodel criteria that was published as harmonization of definitions. And the MIDAS consortium consists of 3 centers that enroll patients: us, Ohio State University; Moffitt Cancer Center, that's in the southern part of the United States; and Roswell Park in the eastern part of the United States. We chose this demographic because Roswell has a more urban, more rural population, but also a high poverty level. So we wanted to study patients from diverse backgrounds. Moffitt has a higher proportion of older patients and Hispanic patients. And our goal is to uniformly screen 1,000 transplant patients. And we estimated that the incidence of TATMA would be 15%. The data is collected prospectively, weekly lab data including hemoglobin platelets, creatinine, LDH, histiocytes. We also collect data on infections and resource utilization, data on GVHD clinical outcomes, and we monitor these data collection and sample collection monthly. And all samples are cryopreserved, batched, and shipped for biomarker measurement to Cincinnati Children's Medical Center. So the REDCap database that the data is stored is managed by Ohio State. And this is the first study in adults that applies the harmonization of definitions criteria in a prospective cohort. TATMA was adjudicated by a 3-member panel, and this panel was myself, Dr. Hahn from Roswell Park, and Dr. Bejanian from Moffitt. And we were blinded to each other's reporting and to the transplant center's reporting of TATMA. So this is just an example of what an adjudication data set that each of the 3 PIs receive. Here you can see the hemoglobin, whether the patient received transfusions, whether they got platelet transfusions, LDH, histiocytes, and creatinine, urine protein as well. In addition to that, we would also see how many antihypertensive medicines the patient was on. Did they have neurologic dysfunction, GVHD diagnosis, and infections? So I wanted to show that these centers were very heterogeneous, and I highlighted some. You can see that Moffitt, the median age was higher, also higher proportion of Hispanic patients, also higher proportion of lymphoid malignancies at Moffitt. Patients seem to be more fitter at Moffitt because OSU and Roswell had higher proportions with patients with comorbid index higher than 0. Also higher proportion of haplodonors at Roswell Park, higher utilization of reduced intensity transplants at Moffitt and Roswell, and GVHD prophylaxis was more PT-Cy based at Moffitt and Roswell. So let's look at how these centers fared. So when we use the harmonization of definition criteria, these are the first 101 patients that I'm reporting. At day plus 100, the cumulative incidence of TATMA was 46.8%. Remember, our hypothesis in the grant was 15%, and the harmonization of criteria showed that it was 46.8%. We recognized quickly that the harmonization of definitions criteria was quite sensitive. Our goal in this grant was to identify a clinically meaningful phenotype of TATMA. When we applied the high risk criteria, virtually all of our patients were high risk. They either had GVHD, infection, high LDH. So we realized that we needed a different set of criteria for severe TATMA. And so we developed a severe TATMA criteria. So essentially, you had to meet the harmonization of definitions diagnostic criteria, but you had to have some end organ damage, either new hypertension, neurologic manifestations, renal dysfunction, or proteinuria. And if you use that criteria, it was 17%. And despite the centers being so heterogeneous in terms of demographics, conditioning regimens, donor sources, the incidence of TATMA and severe TATMA did not significantly differ by center. We also looked at the CHO criteria for all these CHO criteria, EBMT and BMT-CTN, as well as the harmonization of definitions criteria for this data set. So then we have to ask ourselves, so let's look at, we have patients with severe TATMA. We have patients with TATMA, but they're not severe. And then we have patients with no TATMA. So the red curve that you see are those with severe TMA. The blue are no TMA. And the black is not severe TATMA. And you see in the overall survival that the overall survival is significantly lower in severe TATMA. This was very reassuring to us because it validated that criteria that we set as who would be severe TATMA. And this lower overall survival was driven primarily by significantly high non-relapse morbidity occurring as early as within 6 months post-transplantation in the severe TATMA group. But if you notice, the not severe TATMA group and the no TMA group are very similar in terms of overall survival and NRM. Then we looked at what is the timing of TATMA in relation to GVHD. Can you have TMA even without GVHD. So this first plot on your left shows incidence of TATMA in patients who did not have any GVHD. So this swimmer plot, each blue row is a patient. The yellow triangles are TATMA. The black circles are death. This is not severe TATMA. This is showing any TATMA. And you can see that you can certainly have TATMA without any GVHD. And then when you look at max acute GVHD grade 1, you can have a TATMA before onset of GVHD and some TATMA after onset of GVHD. The numbers that I want you to pay attention to are the proportion of severe TMA, because we already established severe TMA is what we care about. That proportion was 9% in those without GVHD. It was 8% in those with grade 1. And in grade 2, you can see that TATMA occurs roughly equally before GVHD or after GVHD. But the proportion of severe TATMA increased from 8% in the previous slides to 23% with grade 2. And then when you look at grade 3, 4, the proportion of severe TATMA was 44%. So TATMA occurs despite no GVHD, but it definitely occurs at a higher proportion with higher grades of GVHD. So then looking at our own centers, we noticed that both TATMA and severe TATMA were underreported by the centers. And these are centers that have an IRB approved protocol. People are thinking about it. And even there, it was underreported. The concordance of TATMA diagnosis between this 3-member panel and the transplant center was low. Of 17 patients that were adjudicated as severe TATMA by our panel, 10 were reported as having TATMA by the center. And for not severe, you could argue, like, is that really impactful, even if they weren't adjudicated? So let's see how these people fared. So this slide shows about TATMA and response to eculizumab. So 17 patients were adjudicated as TATMA by the MIDAS panel, 10 were diagnosed by the center, and 8 received any TATMA-directed therapy. That includes changing from tacrolimus to sirolimus or discontinuing it or eculizumab. 6 out of the 10 received eculizumab, and 2 out of the 6 are alive. Both received eculizumab. And in the not severe TATMA, there were 31 patients that we adjudicated. 5 were diagnosed as TATMA by the center. But all five that were diagnosed received TATMA-directed therapy. 2 of the 5 received eculizumab, and all 5 are alive. So you could even ask, like, did the 2 really need eculizumab? So it's these are questions that we need to answer as the sample size grows, in terms of trying to define what is the clinically meaningful phenotype. So to conclude from the MIDAS part, this is the first prospective study of TATMA to utilize the harmonization of definitions criteria. If you use that criteria, the incidence is quite high, 46%, but not all TATMA is impactful, and hence not all TATMA is actionable. The impactful actionable cases can be identified by the severe TATMA using both the harmonization of definitions criteria plus end organ damage. And the severe TATMA incidence is high. It's high at 17%. And we should care about it because it does impact overall survival and non-relapse mortality. Severe TATMA remains underdiagnosed, and we humbly believe that you need to consider prospective screening. Some of these patients are very sick. There's a lot going on. So unless we screen, we probably wouldn't think about this. The harmonization of definitions criteria is quite sensitive for diagnosis of TATMA. In this very small cohort, very, very small numbers, the efficacy rate to eculizumab in this adult population was only 33% in the severe TATMA group. So this is a Sankey plot that shows how patients, you start out at with 101 patients, and by day 30, you've had some patients with GVHD, some patients with TATMA, some patients who've already lost their lives from TATMA. And then there onwards, you can, after 30 days, if you develop TATMA, you can then go on to develop GVHD and then TATMA and then death as well. So this shows how patients start with and how few patients are spared of neither complication. And that you also have GVHD patients who don't develop TMA ever. So right now we have up to 240 patients who have 1-year follow-up. And we are looking at those patients. We are looking at what are the risk factors at baseline, even before they come to a transplant. And how many of those risk factors are modifiable and how many are not modifiable. For example, age, ethnicity, gender, it's not modifiable. What are the risk factors post transplant? Are there early predictive signs of TATMA within the first 14 days of transplant? And once we have knowledge of those risk factors and early biomarkers, can we then become smarter and design a trial of risk mitigation or early intervention or prophylaxis? So now I'm coming back to the dilemmas in clinical transplant care. I showed you the literature that's there with currently available agents. I showed you the prospective data looking at the study of incidence and risk factors for TATMA. So should we treat TATMA in the setting of steroid responsive? Yes, because TATMA independently contributes to NRM. Similarly, for refractory GVHD as well, we need better agents. But nonetheless, just like you would consider steroid-induced hyperglycemia as a separate problem and be aggressive about that, TATMA should also be considered as a separate problem, and we need to have trials and treatments for that as well. Infections are risk factors for TATMA, so as long as the patient is hemodynamically stable or they don't have active bacteremia, patients can be treated with eculizumab. Um, and concomitant hepatic SOS, there's insufficient data. I know in our own center, when we diagnose someone with both SOS and TATMA and using defibrotide, patients have come off dialysis with a significant improvement in platelet counts. And then once the duration of defibrotide ends, they promptly revert to a TATMA phenotype. So, and then when do we switch or stop TATMA directed therapy? When do we say it's futile and we need to move on? We don't have guidelines, but that same committee that came up with the harmonization of definitions criteria, we reconvened the committee in the first quarter of 2024, and we are now writing the paper in terms of consensus guidelines about what is the response definition and when should we consider switching therapies. Um, and these are some of the questions that I hope that we can discuss in the remaining 15 minutes. So again, CNI discontinuation, I think, is definitely fraught with risk. So I personally would not recommend that as a blanket solution because the risk of triggering a GVHD flare may not be worth it. We also need to have more information on figuring out who are the patients who will self-remit, either with a mild modification in CNI or resolving with underlying risk factor treatment. And why are the response rates to eculizumab so different in children versus adults? Is it a host issue? Why are the response rates lower? Is it because, at least in adult centers, in our own centers, we do not utilize the method recommended by Dr. Jadel, which is PK guided therapy? We have to give only weekly. We cannot give any more frequent than once a week. Or does it mean that complement activation may not be the only pathway in adult TATMA? And how do you all approach TATMA directed treatment in patients with concomitant GVH? And then patients who have normalization of hematologic parameters, but then continue to have organ dysfunction. So these are, after I show the acknowledgement slide, I'm going to have this up so we can use this as a forum for discussion. So the work that I presented from the MIDAS consortium, there's a huge team and they worked hard to get us this data. The people are listed here at all the centers. And finally, many, many thanks to our funding agency, National Heart Lung Blood Institute, without whose support we could not have done this. So this concludes my presentation. I'll have the questions for discussion up, and I look forward to hearing from all of you and in the chat box. Thank you. Thank you for your attention. Okay, so I am looking at the Q&A section. Tran Dertan asked, does combined eculizumab and plasma exchange, is it beneficial than eculizumab alone? In that case, how do you adjust the dosage of eculizumab? So I would say that we routinely do not do plasma exchange because virtually in all our patients, ADAM-TS13 is normal. So our transfusion medicine colleagues and we have come to a consensus that plasma exchange is not beneficial. So so I apologize, I'm not able to answer the second part of your question. But I can, if you give me your contact information, I can connect you to our pharmacist who may be able to uh, reach out to centers, how others are doing it, and get back to you. And then the subsequent question from the same member, will long-term use of eculizumab induce C3b excess associated extravascular hemolytic anemia? We have not seen that. We have seen that in patients who respond, and typically we see patients respond within 4 or 8 weeks. In patients who respond, the hemoglobin and platelets do get better. What can happen is the renal dysfunction may not improve, and you may have anemia from chronic renal dysfunction. But even that, we've had patients where you've treated them with eculizumab, and then 4 years later, they show up with abnormal kidney function, but their hemoglobin is still relatively preserved, and the biopsy shows chronic TATMA with a lot of nephron loss. What's the timing of stopping eculizumab treatment? So please watch for the consensus guidelines. We are hoping to submit the paper within 4 weeks. Um, I think different centers vary. There are some centers that argue that you need to treat for up to 12 weeks before you give up. Personally, when I have a patient who's been on treatment for 8 weeks and has had zero response, or somebody is actively progressing, I have considered compassionate use narsoplimab. So, but please wait for consensus guidelines. Have you observed some TMA with busulfan in autologous transplant? In our center, we do not use busulfan for autologous transplant. It's usually um, um, some thiotepa based regimens. But even in the regimens that we do use busulfan, we maybe I've seen one patient with TMA in the last 13 years in our own centers following autologous transplant. So perhaps the indication might be different in adults. We don't transplant neuroblastoma. It seems to be specific for neuroblastoma and autologous transplant. And then the other question is, if a patient has complement factor mutation, does that mean lifelong treatment? That's a good question. I would still say that um, that the treatment for eculizumab should really be based on whether that clinical phenotype has reversed or not. For example, did the kidney function improve? Did they become transfusion independent? So I'm not aware of anyone receiving lifelong treatment. What are the preventive measures? That's a great question, Wafa Mohammed. In our grant, we are identifying risk groups that may be more predisposed to TATMA, and I think that's the next step. If you already know, just like you have the comorbid index that you can come up with a calculator, we are hoping to develop a calculator about who will ultimately develop TATMA or have NRM due to TATMA. Preventive measures, that's a big question. We really don't understand it. I know in Europe there's a lot of groups that use statins. That's not used widely, but I think that is definitely used in pediatric centers and in by the German transplant group using statins pre-transplant. Have you noticed any trend in higher or lower risk of TATMA in patients receive PTCy? That's a great question. So, initially, when PTCy started becoming increasingly utilized, we thought, well, if GVHD is a risk factor for TATMA and PTCy is very effective at minimizing severe GVHD, we should be seeing lower incidence of TATMA in PTCy. But the data that we have so far in MIDAS does not support that. We are seeing TATMA even in PTCy. We are definitely not seeing a lower risk of TATMA. And I think one reason for that might be for those we give PTCY, we do see BK viral reactivation. And we know that BK virus is a risk factor for TATMA. So whatever benefit from GVHD perhaps may be offset by infections. And that's why we're not seeing. We have not yet seen a lower incidence of TATMA in those who received PTCy. Okay, so let me see if there's anything in the chat or Q&A. I think I've answered most of the questions. Please reach out to me. Email, it's Vasu, last name VASU .7, as in the number 7, at osu.edu if you have any questions. And thank you very much for joining and for the great discussion. Take care. Have a great day.